So now lymphocytic aggregates do not always signify an abnormality of lymphocytes, by which I mean that they can be reactive in many situations. On the other hand, and the frequency of these sort of benign lymphoid aggregates in the bone marrow biopsies is highly variable, and we'll see the reason for that. As it goes by, the talk goes by, it's they range between 1 to 2% to 13% between various studies. Now, remember, this is the frequency of benign lymphoid aggregates. So it does not include those aggregates which ended up being called a lymphoma. And most of these studies that looked at frequencies are slightly older, so they may not have benefited from the very advanced immunophenotyping which is available to us all in this era. The frequency of lymphoid aggregates increases with age, and the highest frequencies are seen in the oldest people. So, in persons who are aged greater than 40 years, one study found that the frequency was between 19 to 27%, and in those who were seriously older, it was between 35 to 45%. Right. And women tend to have a larger frequency of these aggregates than men. And for some reason, perhaps it's a study bias, perhaps there is a biological reason behind it. They seem to be commoner in studies that report Western data as compared to those from the Far East, by which we mean Japan, Taiwan, etc. Now, so these lymphoid aggregates will come, and all of us who report bone marrow biopsies know that it's a very frequent encounter that we have. So, what are the scenarios in which they can cause us uh, some amount of consternation? Well, first of all, is when the marrow is being done for lymphoma staging. So, in such situations, of course, nowadays the scenario is such that we go in for flow cytometry in any staging marrow, regardless of the percentage and the morphology of the lymphocytes on the bone marrow aspirate. So, hopefully, by the time the bone marrow biopsy comes, the lymphocytes have already been immunophenotyped. On the other hand, the challenges really arise when patients who do not have an evidence or a clinical suspicion of lymphoma end up showing us suspicious nodules or infiltrates during the evaluation. And obviously, these patients underwent a bone marrow evaluation, so they are being assessed for another hematological or non-hematological disorder or being worked up for an abnormality. That abnormality could be an unexplained cytopenia, it could be unexplained fever, it could be any of so many things. So when we have a situation like this where a lymphoid aggregate has come up, the clinician has a lymphoma not on top of his list. This is certainly not a case of proven lymphoma, but a lymphoma could explain the manifestations that the patient has come in. Then the pathologist is looked at to tell whether this is the cause of that patient's abnormal physical or laboratory findings. Then we find lymphoid infiltrates that are present in the presence of another clear-cut pathology. And these can be interesting and fun to report out, although you sometimes have to now begin to wonder whether the patient has another pathology in addition to this clear-cut one. A very peculiar problem arises in patients who have been treated for a lymphoma and have residual lymphoid infiltrates after therapy. And that's because now these are people where we need to be looking for evidence of residual disease or recurrence if the patient was declared disease-free earlier. And then the lymphoid infiltrates need to be phenotyped, immunophenotyped, or deeper phenotyped. So clearly, we are dealing with a practice situation where differentiating neoplastic versus reactive lymphoid aggregates in the bone marrow is of paramount importance. And for this, we need to know what are the causes for these two kinds of lymphoid aggregates and how can we make a distinction between them. So there are several non-neoplastic conditions which give rise to lymphoid aggregates in the bone marrow. Like I said, advanced age is one of the commonest reasons why people will have lymphoid aggregates in their bone marrow. In addition, a lot of infections will give rise to this finding as well. These are very typical infections. Viral infections top the list. So people with HIV, hepatitis C, B, viral infections, CMV, viral infections. So any of the longer duration herpes group infections, mycobacterial infections, and miscellaneous fungal and bacterial infections can give rise to lymphoid aggregates. Autoimmune diseases are well known to give rise to lymphocytic proliferations. And so rheumatoid arthritis, SLE, patients who've had these diseases for a long time, they can have non-neoplastic lymphoid aggregates. And in some situations, we need to worry about whether these aggregates could be neoplastic also, and that will come up. Then we have a lot of medications, and some of these medications are those which are well known to be associated with autoimmune phenomena. But there are other more recently or more modern medications like rituximab, like CAR T cells, which give rise to lymphoid infiltrates in a marrow. And obviously, patients who are getting rituximab or CAR T cells are more likely to have follow-up marrows. And specifically for patients who have these chimeric antigen receptor rearranged T cells, if they've received them therapeutically, they can have CD8 positive T cell infiltrates. Multicentric Castleman disease is a plasma cell primary disorder, but this will give rise to lymphoid aggregates. Autoimmune lymphoproliferative syndrome with its typical DNTs is another cause. Smokers can have increased number of circulating lymphocytes as well as a typical morphology, which we'll look at, and lymphoid aggregates. In the past, people have tried to group reactive lymphoid hyperplasias into persistent polyclonal lymphocytosis, polymorphous reactive lymphoid hyperplasia, and systemic polyclonal B cell immunoblastic proliferations. As immunophenotypic and molecular advances have occurred, some of these conditions that we earlier believed to be reactive and either oligoclonal or polyclonal are now recognized to be actually precursors of lymphomas. There are geographic variations, like I said, in the Western world, and in some parts of Africa, the lymphoid aggregates in reported series are more common. And then, of course, there's a big group of patients where we find a lymphoid aggregate. There is no systemic evidence for or a lymph node evidence for a lymphoma. And after appropriate ancillary testing, it is declared that this lymphoid aggregate is idiopathic. Maybe there's an undetected infection or an autoimmune disorder. On the other hand, neoplastic conditions which are associated with lymphoid aggregates obviously will include the lymphoproliferative disorders primarily. And within this, the top category would be non-Hodgkin B-cell lymphomas, or some of them which can come in a leukemic phase as well, which we call the CLPDs. Hodgkin lymphomas will tend to have lymphocytic infiltrates as well. These are not the neoplastic clone, because the neoplastic cells in this are in a minority. They are the Hodgkin or the RS cells, but the background T cells can sometimes cause problems in interpretation. T and NK cell lymphomas can be problematic. We'll spend some time on them. In plasma cell neoplasms, now the cell of interest in these neoplasms is the plasma cell, which is a late post-germinal center kind of a B cell. But in certain situations, they can create problems. Sometimes the neoplastic cells themselves can look like lymphocytes, for instance, in myelomas, which have the translocation 11-14, as well as in patients who have the POEMS or the Tempe syndrome, where we can get lymphoid aggregates aplenty. In addition, the myeloid neoplasms are not safe either. The MPNs, especially PMF and PV, have a high frequency of lymphoid aggregates. MDS, the current nomenclature for them is myelodysplastic neoplasms, will also have a frequency of approximately 10%, showing lymphoid infiltrates. Some of these patients can show responses to immunosuppressive therapy. There are some papers suggesting that. Lymphoid infiltrates are common in systemic mastocytosis and disorders associated with eosinophilia as well. So now let's just try and look at some features of reactive lymphoid aggregates. At the most basic level, because these are reactive, they will show admixed B and T cells. And just as in the normal bone marrow, the T cells will predominate, which means we will get a T cell to B cell ratio of either 4 or 5:1. So a big predominance of T cells. Of course, therefore, if we get a B cell predominant pattern, we should follow it up further with the clinical history as well as special investigations. They're a little easier in the case of B cells to rule out a lymphoma. But the caveat is that just because we have a T cell dominant pattern, it does not automatically rule out a lymphoma. So this is an example of a reactive lymphoid aggregate. It is, It is non-paratrabecular in location. It has clear non-infiltrative margins. These lymphocytes, had I zoomed into them, would have been small, mature-appearing lymphocytes, and especially towards the periphery, they tend to be admixed with small numbers of fibroblastic reticulum cells and even smaller numbers of plasma cells, eosinophils, and mast cells. Like I said, every rule has an exception. So if you have an appearance like this, but you're getting a lot of plasma cells, eosinophils, then of course there are other lymphomatous entities also which can sometimes be thought of, but this is a general rule that if you're getting a polymorphous infiltrate, you think of a benign. Germinal center formation is not frequent, but if it is there, one would tend to favor a benign etiology. These germinal centers are cytologically identical to the secondary lymphoid follicles in lymph nodes or MALT. Um, they're of course infrequent, and when I say cytologically identical, I mean that the ratio of centrocytes to centroblasts will usually be very high. We will not get larger atypical looking cells as a big feature of these germinal centers. So I told you that there were certain patterns which had been described in the past. So of these, the ones which are classic are persistent polyclonal B cell lymphocytosis. This is a very typical phenotype according to literature. Middle-aged women smokers. A lot of smokers in India may not be comfortable admitting anymore that they smoke. So you may or may not have this history forthcoming. The typical feature here is binucleated lymphocytes, and they showed increased polytypic IgM, and there is something of interest which is coming up on the next slide regarding this. The other entity which is encountered occasionally is a polymorphous reactive lymphoid hyperplasia. This is associated with numerous conditions, by which we mean that this is a secondary phenomenon to malignancy, bone marrow, mostly metastasis, post bone marrow transplantation, post chemotherapy, infections, autoimmune disorders, etc. And another confounder which can sometimes really make us worry is hematogone hyperplasia. Although here the hematogones worry us because they can be confused with blasts. So this is a specific example of a polymorphous reactive lymphoid hyperplasia. The mean hematogone percentage in specimens from healthy volunteers is about 2%. And so if we detect more than 5% of hematogones, and flow cytometry is, of course, the test of choice to detect them, it is considered as a hematogone hyperplasia. This is increased in several hematological and non-hematological disorders. It is a physiological finding in very young children, mostly, especially in infants. They go up following hematopoietic stem cell transplantation and chemotherapy, in viral infections, ITP, PRCA, in copper deficiency. This can mimic myelodysplasia. They go up in storage disorders, some bone marrow failure syndromes, and in malignancies. So hematogones can, of course, be very vexatious morphologically. On a bone marrow biopsy, I don't think anybody is going to even try and distinguish them from lymphocytes in this era because they're going to be very difficult. So how do we distinguish them from B lymphoblasts? They become of practical importance in regenerating marrows post-induction in B ALL. And so because hematogones typically will be a spectrum of cells. They are normal cells, remember, that range from immature to mature. They express their antigens synchronously, and therefore the strength of expression of the antigens will vary and vary appropriately according to the stage of their maturation. This will not be the case with lymphoblasts, malignant lymphoblasts, because they will show asynchronous co-expressions, and they may show expressions which are inappropriately low or very high to their stage of maturation. And blasts, unlike hematogones, can very conveniently for diagnosticians end up showing aberrant expressions of antigens. So I'd just like to show you, hematogones are a totally different topic for another class, but just to finish them off here, they will typically tend to have much lower side scatter. This is a 45 side scatter plot than the residual blasts in this particular case. They show a spectrum of maturation, but the problem will arise because they, of course, morphologically mimic, as well as flow cytometrically in this particular plot, they will lie in the blast window, especially the earlier forms of hematogones. Turning our attention now to neoplastic lymphoid aggregates, these are going to be frequently encountered, and mostly we will have a patient who already has a lymphoma, and we are now being called upon to stage it. So at this point, it is useful to have a certain idea in our heads about the frequencies of marrow involvement in various BNHL. So it can be very high to very low, and the thumb rule is that the more indolent, the more chronic, and the more low grade the NHL, the longer time it has had to incubate and to spread, and therefore the higher the risk of marrow being involved in that. So this sounds a little paradoxical because one would expect higher grade aggressive lymphomas to involve the marrow more frequently, but you will notice that things like small lymphocytic lymphoma and marginal zone lymphoma and lymphoplasmacytic lymphoma which are all lower grade indolent lymphomas for the most part, tend to have very high rates of marrow involvement. On the other hand, the commonest variety of B cell NHL, which is a diffuse large B cell lymphoma, tends to have lower grades, usually 25 to 30%. This particular paper, there's a good study by Daniel Arbour, which found it to involve a range of 10 to 30%. Burkitt lymphoma, another aggressive neoplasm, very aggressive neoplasm, involves the bone marrow in 15 to 35% of cases. Mantle cell lymphoma, we now have the classification where it can vary from in the clinical behavior, tends to involve the marrow at a higher rate, 50 to 80%. Again, the more indolent, the peripheral blood involving forms that are there, the non-nodal ones, they tend to have higher rates of marrow involvement. Follicular lymphoma, 40 to 70%. On the other hand, when we turn our attention to T cell and NK cell lymphomas, this can range from very low frequencies like the Sézary syndrome, less than 2%. So this is something to bear in mind when we're trying to look for Sézary cells. This frequency goes up if the patient has mycosis fungoides. It goes up tremendously. On the other hand, anaplastic large cell lymphoma, again, involves the marrow in just about 15 to 25% of the cases. This is a T cell lymphoma. One must remember, however, that about 80% or 70% of the cases are going to be CD3 negative. So one needs to have a high index of suspicion in the bone marrow biopsy and probably go ahead to pick up these 15 to 25% cases. Immunohistochemistry is frequently required to confirm them. T cell lymphomas with very high frequencies of involvement, hepatosplenic T cell lymphoma, aggressive NK T cell lymphomas, these tend to have a high frequency of involvement, more than 95%. Angioimmunoblastic T cell lymphomas, these are slowly becoming the most predominant variety of T cell lymphomas that are encountered in lymph node diagnostic practice. And remember that they will involve the bone marrow in more than 50% of the cases. These can be extremely challenging to pick up on the bone marrow biopsy. Even and especially if you're flow cytometrist. I'm lucky to have very expert flow cytometry colleagues with me, but these can be very tricky entities, and that's why we'll look at them in a little more detail down the line. Hodgkin lymphoma, my talk today is not going to be dealing with Hodgkin in any great detail because it's a bone marrow involvement is a very beautiful and unique topic there. But just remember that the NLPHL virtually never involves the bone marrow, and which is why the DD of this nodular lymphocyte predominant Hodgkin lymphoma, which is T cell rich B cell non-Hodgkin lymphoma. So if you're getting very large B cells surrounded by a lot of T cells, it is always more likely to be a T cell rich B cell non-Hodgkin lymphoma rather than an NLPHL. Sometimes after the bone marrow, if the bone marrow is involved, you review the biopsy, the lymph node biopsy, and the diagnosis gets revised because an NLPHL virtually never involves the bone marrow. Within the classical subtypes, the lymphocyte depleted, the poor prognostic type, tends to involve the marrow much more frequently. In any case, with the advent of imaging techniques, staging marrows in Hodgkin lymphoma have come down quite a bit. So with that theoretical bit out of the way, although that's very important because we need to be cognizant of a lot of theory to be able to apply that to the picture, let's turn our attention to marrow examination in the diagnostic workup of patients with lymphoma. So if you have a patient with, now this is a specific situation, you have a patient with lymphoma, we're trying to see why do we do a marrow at all? So what is the role? In diagnosis and differential diagnosis. So it is not uncommon for the initial diagnosis of the bone marrow examination in CLPDs, by which I mean the leukemias and lymphomas that primarily involve the peripheral blood and bone marrow, to happen by means of the bone marrow evaluation. For example, TLGL leukemia, PLL, lymphoplasmacytic lymphoma or Waldenstrom, macroglobulinemia, hairy cell leukemia, etc., will virtually always get diagnosed on a bone marrow evaluation. In addition, there's an entity called the primary bone marrow lymphoma. It's a very rare entity. It's an entity that one diagnoses with a lot of caution. And here, clearly, the bone marrow is going to be the key process in its diagnosis. Sometimes we will have patients who have disseminated lymphomas or patients who have splenomegaly as their major feature of a lymphoma or whose lesions are inaccessible for biopsy. And in such a situations, the clinicians may contact us for with the to discuss that this patient is highly likely to have a lymphoma and we need to a bone marrow, do a bone marrow to establish the diagnosis. In addition, the bone marrow has a role in staging and prognosis. I mean, that goes without saying. So bone marrow involvement equates with high stage disease and therefore has a significant impact on prognosis. And this is especially important for the aggressive B-cell lymphomas where the frequencies of involvement are not very high. So by which I mean that if you have a DLBCL which is involving the bone marrow, that's really changing the changing the prognosis of the patient. On the other hand, a lymphoplasmacytic lymphoma involving the bone marrow, yeah, obviously, mostly you diagnose them on the bone marrow itself. So the involvement of the bone marrow affects both the IPI because it upstages the disease to stage 4 as well as it counts as extranodal involvement. Sometimes bone marrow involvement can help in selection of appropriate therapeutic approaches, especially in cases of patients with Hodgkin lymphoma where local approaches may still be feasible. It definitely helps us monitor the response to treatment as well as detect relapses during follow-up. So this is a big role, and unfortunately, I won't have time to spend on this, and maybe a class on MRD monitoring in lymphoproliferative disorders would be there in the future. So when we're going to be doing bone marrow biopsies to stage lymphomas, we need to have an adequate specimen. It goes without saying. So and that's because lymphomas frequently show focal involvement. So the larger your specimen, this is like a gorgeous biopsy, the more likely you are to be able to pick up very, very focal deposits. So the core should be at least 1.5 to 2 centimeters long. And in addition, the core should definitely contain sufficient intact bone marrow for evaluation. So occasionally we'll get bone marrow biopsies from outside where the core looks very nice when you look at the block, but when you evaluate it, it consists of mainly cortical bone and subcortical marrow spaces which are totally washed off and disrupted. So they cannot be considered adequate, and one must document this in the report as well. If the marrow is involved even with a core like this, then of course one's comfortable. But if it's uninvolved, then it is with that limitation. At my center, which is PGI Chandigarh, we do bilateral iliac crest biopsies in all staging bone marrows to maximize the detection of lymphoma, although the aspirate is typically taken from a unilateral site. So so when you're going to be getting these bone marrow biopsies, we need a certain amount of crucial clinical information to be able to interpret them. And sometimes my clinical friends are going to ask me, Prashant, what difference is it going to make whether I give you this information or I don't give you? What you're going to be seeing on the bone marrow biopsy is going to be the same anyway. The words I put on the form aren't going to change what's there on the slide. So in the next few slides, we're going to be taking a look as to how that makes a difference, because I am aware that a lot of clinicians also listen to these talks. So of course, we need the basic demographic data. We need to know the indication for a bone marrow biopsy. If you're doing it for HLH, you need to let us know how likely HLH is based on your H score. A bone marrow can never be seen without a CBC and a peripheral blood evaluation. If the patient is a known case of lymphoma, we need to know what the classification is. Even if it's not a complete classification yet, ancillary studies are in progress that should be communicated. Key immunophenotypic characteristics, pertinent molecular genetic and cytogenetic results. Lymphadenopathy and hepatosplenomegaly are sine qua non for bone marrow forms. They're always needed. In addition, if there are constitutional symptoms, please mention. Then please ask for them. If the patient has a history of inflammatory, immune, or autoimmune disorders, for example, rheumatoid arthritis and lupus, it is important for the pathologist to know why that was there, and especially if what treatment was administered for them. If the patient has had a transplant, if there are contributing factors for iatrogenic immunodeficiency like methotrexate, infliximab, or other TNF-alpha antagonists, the HIV status of the patient, any pertinent serology that's already been done, especially in patients with PUO, this will often be available. Other laboratory data. So if an serum protein electrophoresis, a direct Coombs test, LDH, all these beta-2 microglobulin are already available, it's always a good idea because to let the lab know. So let's try. Why do we need the peripheral blood in all situations? And when we get it, it's important to be able to, important to be looking at it carefully. So in this particular patient with splenic marginal zone lymphoma, we can see this classical abnormal lymphocyte with a circumferential, moderate amount of cytoplasm. And I mean, the books say bipolar, but cells don't read the books. So we can see these fuzzy margins. And this is the bone marrow biopsy. So if I didn't have the history of a massive splenomegaly in this patient, and suppose there was a leukopenia, this can very easily be just seen as a subtle lymphoid infiltrate. But the moment we got a CD20 stain, and just see how it just lights up the intrasinusoidal pattern. So the lesson is that subtle morphological features of the lymphocytes may be better appreciated in a peripheral blood smear rather than an aspirate and an imprint. So uh, because there the cells tend to be showing a higher NC ratio in general. Another situation, less common though, where peripheral blood morphology is helpful is if we see cells like these with very folded nuclei. And if I tell you that these cells are CD3 positive, 4 positive, and 5 positive, and negative for CD2, 7, and CD8, then take a second. Yeah, clearly these are Sézary cells. So again, the peripheral blood is important. The role of the clinical background. So this is a patient with a TLGL leukemia. Again, the bone marrow biopsy is very deceptively showing just a subtle interstitial lymphocytosis. This patient had pancytopenia and yes, uh, uh, but the moment we do a CD3, it just lights up. And again, we've got an intrasinusoidal pattern of infiltration, and this can be very difficult to see on an HE stain. And it depends a lot on the thinness of your section. Typically, nothing more than 4, 5, I would say like 3 to 4 microns, but nothing more than 5 definitely is going to be able to pick up these sort of subtle findings. So, knowing the primary site diagnosis. So sometimes we can have lymphomas with discordant morphology. These have been studied very well in the past, and they're not uncommon. So there can be a by discordant morphology, we mean that the morphology in the bone marrow, which is more often a low-grade small cell type, is different from the morphology that was seen in the periphery, which is, in this case, a DLBCL. So this may, however, this may of course reflect a progression to a higher grade in the lymph node. So we may be seeing a precursor lesion within the bone marrow. And of course, as science has evolved, we know that they may be totally unrelated. We may have a DLBCL in the lymph node, and we may have a monoclonal B-cell lymphocytosis in the uh, uh, in the bone marrow. Now, monoclonal B-cell lymphocytosis is a peripheral blood diagnosis, but if you happen to do a flow cytometry on the bone marrow, you'll again pick it up. Um, if the patient has received prior therapy, it's again useful to know that, because this is a paratrabecular lymphoid aggregate, which is very worrisome. We just discussed that they tend to be neoplastic. Now, this patient has received rituximab therapy, and when immunohistochemistry was done, all of these cells turned out to be CD3 positive cells. How does one rule out a B cell residual lymphoma in this? You can't use CD20 because the relapse or the residue is going to be mostly CD20 negative. So alternative markers like CD79A will have to be used. So these cells were negative for CD79A and CD3. So these are reactive lymphoid infiltrates after rituximab therapy. So CD79A, some of you may be wondering, is used as a marker on flow cytometry of immature B cell. So how can I use it in a mature B cell neoplasm? Well, on immunohistochemistry, it works very well as an uh, marker for uh, B cells per se, not mature or immature. And that's because, remember in flow cytometry of acute leukemia, CD79A has to be done using permeabilization. It is a cytoplasmic marker, which means that the epitope that we're looking for is actually within the membrane, and which is why mature B cells are going to be negative for this. On bone marrow sections, however, we have actually sliced through the cells, right? And so therefore, this epitope is now available for our immunohistochemistry antibody to bind. So also another if importance of prior therapy in some patients who are treated for lymphoplasmacytic lymphomas, the lymphocytes disappear, but the plasma cells persist, and this may mimic a plasma cell neoplasm. And these plasma cells are, however, non-clonal, and therefore one needs to know what's going on. Then there are patterns and there are patterns. So I could have spent a lot of time on them, but I thought I would finish it off in this slide because A, most people would be aware of these patterns already. So let's just see. Predominantly paratrabecular pattern is classically seen in a follicular lymphoma. By no means is it restricted to it because we can see a mixed paratrabecular and interstitial pattern also in Waldenstrom and extranodal marginal zone, nodal marginal zone, splenic marginal zone, and mantle. Nodular patterns are typically seen in CLL, SLL, but also in mantle and the marginal zones. Interstitial infiltrates would be typically early infiltrates of any neoplasm, but they can be especially capricious in DLBCL as well as the other lymphomas which involve the marrow more regularly. A diffuse pattern typically indicates an advanced level of infiltration. In this particular group comes hairy cell leukemia, which often is not a problem to diagnose on the bone marrow biopsy because of its typical fried egg appearance. Uh, a sinusoidal pattern is seen in splenic marginal zone lymphoma, extranodal marginal zone lymphoma, and in intravascular DLBCL. So this is a slide which is telling us about the B cell lymphomas. And I told you that the NKT lymphomas can also show us this sinusoidal pattern of infiltration. Single cells are often seen in DLBCL. Their prognostic implication has been debated in the past, but now if you're getting them on flow cytometry, it gets upstaged. They are lymphohistiocytic lesions, by which we mean there is a mixture of lymphocytes and histiocytes. These are seen in classical Hodgkin lymphoma and T-cell rich, histiocyte rich B-cell lymphoma. We'll turn our attention out of all of these patterns to one which is often a cause of difficulty in clinical practice, and that is a reactive versus neoplastic distinction in T cell infiltrates in the bone marrow. And the reason why we're not going to spend time too much on the B cells is because in this era, the flow cytometrists will walk away with all the trophies because the case is going to go to them. They'll get a kappa or a lambda restricted population, or they'll get aberrancies, which are very, very clinching in the case of B cells. And that's the end of the story. On the other hand, for T cell proliferations, the bone marrow biopsy still has a role to play and sometimes a pivotal role to play. So just to revise quickly the differences between benign and neoplastic aggregates, a last look at the rules before we start breaking them. Benign aggregates are going to be small sized, randomly distributed, few in number, rounded, well-defined margins. They're going to be discrete, not confluent. They are low reticulin content and often will show increased vascularity. You'll get little capillary sized or arterial sometimes sized channels in the center or sides of it. Germinal centers may be present, not always. They are intertrabecular, sometimes perivascular. They are polymorphous in their cellular composition, by which I mean there will be a mixture of different cell types, lymphocytes, reticulum cells, plasma cells, histiocytes, eosinophils. On the other hand, neoplastic aggregates tend to have a pleomorphic component, by which I mean the neoplastic cells will show a variation in morphology. We have an example coming up very soon. IHC is to the rescue in these because they show a B and T mixed aggregates, no light chain restriction on flow cytometry. If it's a T cell lymphoma, no T cell abnormalities if you're lucky, and no BCR or TCR rearrangements on molecular testing. With that, we now come to what it actually is in real life. So the distinction of TNHL versus reactive changes is actually one of the most challenging distinctions that the morphologist can face. And that's because even heavy marrow infiltration by T cells is not a proof for a diagnosis of TNHL. And conversely, a subtle infiltrate of T cells does not rule out TNHL either. So interstitial T cells can be seen in viral infections, autoimmune disorders, which are typically T cell rich. And they're usually small lymphocytes lacking atypia without an aberrant phenotype. And sometimes we can see remnants of B cell follicles, which may have residual germinal centers, atretic germinal centers, and these also suggest a benign infiltrate. The reason why we're still spending time on benign infiltrates in this talk is because you don't want to accidentally diagnose a neoplastic condition in a bone marrow, a neoplastic lymphoma in a bone marrow, when it's not there, right? So sometimes, if in doubt, it's the usual teaching is to err on the side of deferring it to higher investigations and looking at clonality, although they all have their Achilles heels. So basically waiting for the results to come in. So we can have T cell nodules. They are frequently seen in old age. They tend to be evenly distributed in the elderly without any selective paratrabecular pattern. And these are the conditions, autoimmune disorders, MPNs and MDS. And so sometimes they can mislead you and take you away from the correct diagnosis. And in cases of toxic myelopathy and malnutrition, not very uncommon in the elderly, and viral infections. So in this particular case, we have this lymphocytic infiltrate, which is when we do a CD3, it is paratrabecular, and a PD-1 staining was done. So any thoughts as to how this immunohistochemistry, you can think about it in your mind. This a particular patient showed a lymphocytic infiltrate consisting of lymphocytes, histiocytes, plasma cells, and eosinophils, as well as atypical CD4 positive lymphocytes with clear cytoplasm. So again, you see these, and these are not hairy cells. You'd know that from your flow cytometry. And sometimes these patients can have a lot of autoimmune phenomena. The entity I'm taking you towards with PD-1. So your time is up now to guess. This is angioimmunoblastic T cell lymphoma. We need to show the presence of follicular T helper cell type of antigens on these, and there's a whole plethora of them available. I only listed the ones which are likely to be available in addition to PD-1 in a standard pathology department. CD4, 10, and BCL6 would be positive in the infiltrating cells, in addition to all the histological features which are there in the lymph node as well as in the bone marrow. We'll just quickly turn our attention to ancillary techniques, although by no means this is going to be an exhaustive discussion. So immunohistochemistry is invaluable in the assessment of bone marrow lymphoid infiltrates. For instance, we can see, and of course, this is something that I don't really need to tell this. We've been seeing immunohistochemistry throughout this talk, but in this particular example, this is a patient in whom bone marrow was done for a peripheral neuropathy and very vague multisystemic symptoms, and there were lymphoid infiltrates with a slight subtle germinal center, and now these stains are actually lambda surface light chains and a CD138, and we can see that the lambda restricted plasma cells are getting highlighted. So remember I told you that the causes of benign aggregates, I mentioned TEMPI and the other plasma cell disorder there. So this is a very typical pattern that we see in the Poems syndrome, where the neoplastic plasma cells are going to be restricted. On the aspirate, they're going to be much fewer in number, so you may miss them there. They might, of course, get caught on the flow cytometry. They tend to be lambda restricted most of the times, and they tend to be present around the lymphoid infiltrates. Flow cytometry on bone marrow lymphoid infiltrates is a lifesaver because it detects abnormal B cells and T cells based on surrogate markers of clonality. For B cells, this is easy because there's kappa and lambda expression, and a kappa lambda ratio of greater than 3 or less than 0.5 will tell us. So don't just look for the presence of the two populations, look at the ratio. In this particular case, the B cells are 99.5%, whereas the lambda restricted cells are 99.5%, whereas the kappa restricted cells are 0.4%. For plasma cells, we need to look at the cytoplasmic kappa lambda expression, and plasma cells are very kind. They often show us aberrant antigenic expression, so they're good to catch that way as well. Then flow cytometry of T cells is slightly more challenging. In the first generation of assays, or which is probably like many, many years ago now, we used to rely on aberrant antigen expression. So a common abnormalities or downregulation of surface CD3, very commonly CD7 or 5 used to be lost, or a skewed CD4 to 8 ratio. And especially if there was an expansion of a double positive or a double negative 4-8 population. Unfortunately, all of these were uncommon in terms of 4 to 8 ratios. They were difficult to interpret. And in addition, over time, literature accumulated that reactive conditions like viral infections, like especially the long-standing viral infections like the hepatitis groups, autoimmune disorders, they can show very similar antigenic aberrancies. So this led to the development of a complex flow cytometric test, which was the V beta repertoire. This was a multi-tube test which relied on the uh, monotypic nature of the V beta part of the receptor. Now, of course, we rely on the TRBC1 and TRBC2 expression, and these antibodies, even a single one of them is sufficient. So TRBC1 expression is analogous to kappa lambda expression in B cells, which means a disproportionately high or low number of TRBC1 events will suggest a clonality. It is inexpensive. It is just one antibody. It's technically simpler, and it can be incorporated into standard T cell tubes. The disadvantage is that they cannot characterize gamma delta T cells because they don't express the beta chain, the TCR constant beta chain 1, which is the target of this particular antibody. And these slides were kindly loaned to me by my colleague Nabajit. So these are normal T cells which are polytypic for their TRBC1 expression, and we can see here on the scattered plot that the TRBC1, this cells are splitting. And on the other hand, the monotypic cells will have a predominant population which are either negative or positive. And that can be seen over here. So of course, this is something which can be problematic if these two peaks are similar sized. And therefore, therefore antibodies have been standardized to show to develop cutoffs. So we need either greater than 85% of TRBC1 positive events or less than 15% of TRBC1 positive events. So they should be skewing on either side for us to be calling them clonal. And remember, none of the tests that I'm talking about today, whether it's morphology, immunohistochemistry, flow cytometry, or molecular, work in isolation, and which is why a consolidated report is the ideal for a lymphoma staging. Moving on very quickly to TCR clonality assessment. So an international consortium called the Biomed2 has developed antibodies for these, and this is a neoplastic clone wherein we can see, so this is the spectrum across which they looked, and luckily we got 3 peaks over here, which means that there was restriction. Sometimes you can just get a peak on the edge, and one will have to give credence to that as well. And by which this is the TCR gamma or beta chains which are getting sequenced, which are getting fragment analyzed using a mix of primers. On the other hand, a polyclonal pattern is going to look like this, and this is what normal people's T cells would have. So this assay can be done on sorted T cells from a bone marrow aspirate, or it can be done on a bone marrow biopsy specimen from which DNA has been extracted. This, however, is an assay which looks very attractive in theory, but one must be aware of certain issues that can beset this. For instance, this is very dependent on the DNA quality, because if one has fragmentation, suppose the fragment which is getting amplified is 200 base pairs long, but the block that you've been sent has a very, very degraded DNA, which is also near that particular length. It could look like a clonal process, even though there is no clonality there. The size of the lymphoid population is important when you're trying to do the TCR V beta TCR molecular analysis, because we tend to think of PCRs as exquisitely sensitive, but because this assay is dependent on the percentage of lymphocytes which is present in the sample that we've taken, and sometimes in T cell lymphomas, that percentage may not be very high. The infiltrates may be very subtle. The sensitivity limits are just about good to moderate using gene scan or heteroduplicate analysis. These assays depend on the type of NHL. So the ones, paradoxically, which are the most difficult to pick up morphologically also tend to be difficult to because these can show ongoing somatic hypermutations of the heavy chain locus. And therefore, so we may have multiple clones that are present and give rise to a false negative or a false normal result. And of course, clonality is not equivalent to malignancy, because we know that we can have monoclonal B cells or monoclonal gammopathies, which are not malignant neoplasms. Follicular T helper cell neoplasms will frequently have clonal B cell expansions. Sometimes they can go on to develop B cell neoplasms. And PTLD frequently post-transplant lymphoproliferative disorders will have clonal proliferations coming and going, and we only call it lymphoma beyond a certain critical level. So, and now towards the end of my talk, I'll be um, zipping through three case-based examples to illustrate the principles that we've looked at in this particular session. So, this first case is a 61-year-old male who came with easy fatigability and visual disturbances, a very leading history. The outside bone marrow had been done. It was suggestive of NHL, but he didn't have any lymph nodes which were larger. And of course, in some centers, it may be easier to do a bone marrow than take a date from the surgeon for a minor OT and get a lymph node biopsy. So a bone marrow may be done even before. So this patient has hepatosplenomegaly, older male. This is the peripheral blood, and the cause for his visual disturbance is right here. So much rouleau formation. He's got severe anemia, thrombocytopenia, and there's a lot of rouleau formation. And this is the bone marrow, and already we can see these plasma cells as well as these lymphocytes. So a closer look, we've seen 35% lymphocytes, 15% plasma cells, as well as some cells which are intermediate. So very clear-cut plasma cells over here, some lymphocytes with more cytoplasm, and of course lymphocytes which are just lymphocytes. So a closer view to convince you that you've got lymphocytes and plasma cells, and these are mast cells. So quite a clincher here. This was an imprint. Sometimes the percentages are more faithfully represented over there. And yeah, okay. So this is the bone marrow biopsy. It's typically got infiltrates which are not very cohesive. So this is what the WHO means when they say, I think we all know we talk about Waldenstrom macroglobulinemia here because it's involving the bone marrow. We need to, of course, confirm the paraprotein. And now these infiltrates are slightly spread out, which suggests that there are cells in between them as well. So these are interstitial infiltrates, but they're so predominant in number that there's no missing them. A closer look is confirming the lymphocytic and plasma cell nature. Plasma cells can, of course, be slightly difficult to catch on the bone marrow biopsy. There is some reticulin fibrosis going on as well. So 1+ to 2+ on the UMNET scale is a pretty high fibrosis. CD20 was done for some reason. Typically, they'll get diagnosed in flow cytometry nowadays. So we are seeing aggregates which are away from the marrow spaces. So this is, and then some which are there, but never be too confident in areas which are getting crushed. And this is a CD3 showing just scattered T cells. This is this CD20 to CD3 ratio is not what you would get in a normal bone marrow or in a reactive lymphoid infiltrate as well. This case had one more surprise for us. There were thick-walled blood vessels, and there was on Congo red staining, there was an apple greenish, maybe I can convince you, birefringence happening. So on flow cytometry, this was a 5 negative, 10 negative B cell neoplasm with a surface lambda chain restriction. The classic MYD88 L265P mutation was positive, and immunofixation very conveniently told us that he had a very heavy IgM M band. So again, maybe I'll just tell this here. So a very high, so IgM by no means is specific for Waldenstrom or LPLs. You can sometimes get it in other neoplasms as well, including IgM myelomas, right? But in those neoplasms, the quantity of the M band is typically lower than 3 grams per deciliter. So a high IgM levels favors a Waldenstrom if you are unsure of what the cause for that M band is. On the other hand, if we take all the cases of Waldenstrom macroglobulinemia, they will have a whole spectrum of quantity of paraprotein. So what I'm trying to say is that it's not as though all Waldenstroms will have a very high quantity, but a B cell neoplasm which has a very high quantity of an IgM paraprotein is more likely to be a Waldenstrom than another IgM B cell neoplasm. So the diagnosis here is, of course, an LPL. This will qualify for Waldenstrom because it's got marrow involvement and it's got an IgM paraprotein with amyloidosis. Moving on quickly to a lovely case, and I think I will try and squeeze this through. This was kindly loaned to me by my colleague Manupdesh, who's a real expert, not just in flow cytometry, but also in morphology. So thanks, Man, for this, and Navjeet for the slides earlier. So this is a young man with generalized weakness and jaundice, and he's pretty sick. He's got hepatosplenomegaly and he's got pancytopenia. So sometimes the history is so short they can get mistaken for acute leukemia, but I won't show you a case of acute leukemia here. So this is the peripheral blood. Like I said, he's got pancytopenia, and there's some cells, but these could just be a plasmacytoid lymphocyte. So nothing much to write home about in the peripheral blood. This is the bone marrow for a 22-year-old. It's looking like maybe a little hypercellular, maybe normal cellular. It's got a lot of cells. I need to go closer. So when we go closer, we can already see that there are abnormal cells within this bone marrow. Here they are. And these cells tend to have a high NC ratio. They have a chromatin which is tending to clump up, but not as, but it's not opened up so as to suggest blasts, although you could be forgiven for keeping that differential diagnosis as well. I mean, on this cell, why not? There's no nucleolus, and it's very high NC ratio. Similarly, these guys have nucleoli. So again, a very open-ended case so far. This could be an acute leukemia uh, as well. So this is the imprint, and here the morphology is more reminiscent of lymphocytes. But in such a case, I guess it would be prudent to at least get one of the acute Luke tubes done. Maybe look for a CD34 and 45 because they are often clues to the mature versus precursor kind of a neoplasm. So we've got a marrow which is infiltrated by abnormal cells in no small numbers. And this is the bone marrow biopsy. Okay, so now this bone marrow biopsy is not like an acute leukemia. It is normocellular for this patient's age, and it's not looking like a monotypic infiltrate that we get even in the hypoplastic acute lukes where all the cells look similar. So let's go closer, and certainly a polymorphous infiltrate, but we can begin to see that already there are these clusters. Yes, and they're tending to form little aggregates, and these are getting picked up because they are paler staining because of their moderate amount of cytoplasm as compared to the surrounding bone marrow. These are the erythroid cells. There are so a slightly closer view, even higher, of showing these cells. So these are our abnormal cells, and they are tending to have, and we can see the endothelial cells which are surrounding these clusters. So again, a more classic intra-sinusoidal infiltration. So in such a case, we will need immunohistochemistry, and that's exactly what was done. This is CD20, they're all negative. This is CD3, and it's beautifully highlighting these serpiginous infiltrates and confirming that we are indeed looking at a T cell neoplasm. Meanwhile, the flow cytometry had come in, and this was a hepatosplenic T cell lymphoma. It was gamma delta receptor positive on flow cytometry. It was CD5 negative. There were no immaturity markers, and these cells had a slightly higher side scatter, but they were CD45 bright. So this is an aggressive neoplasm, and the isochromosome 7q is a common event. So if you have that, one can check for that. In the these are very aggressive neoplasms, and often one needs to be working actively to rule out an acute leukemia. So this is the classic immunophenotype, and they're of typical T cells. They're usually dual negative for 4 and 8, and mostly CD5 negative, which is a good clue. And the gamma delta TCRs on flow cytometry will be positive. Okay, so that was a hepatosplenic gamma delta T cell lymphoma with an intrasinusoidal pattern. So this is actually case 3. The first one was Waldenstrom. So this is the last case, and I think we'll just zip through this. This is a 60-year-old male. He seemed to be an open and shut case initially. He came with a splenomegaly, which was very, very large, and with B symptoms, that is night sweats. So he was planned for an endoscopic for a transbronchial FNA, and this is what it showed. So so this is an easy one. There was a lymphocyte-rich background for the cytologists because they see much more of these. We don't see RS cells so much on our bone marrow aspirates, but there was this large mononuclear cell. This will have to be called Hodgkin in light of what we know knew subsequently, and this is possibly a binucleate cell with very large nuclei. So these are better examples of very large cells, very prominent nucleoli, and this is classic, right? So this is looking like a Hodgkin lymphoma. It's a bimodal age incidence. So this is happening in an older person. So no doubts there. So he underwent a staging bone marrow. This was particulate and hypercellular. And we're getting 33% lymphocytes. And these lymphocytes are very, very monotonous. So, of course, there is only so far that morphology can go. But if you're getting very monotonous lymphocytes in a bone marrow in a patient who's being staged for Hodgkin, at the very least, we would think of the marrow is going to be infiltrated, but no harm in still looking at the immunophenotype. So in addition, on the imprint, we could see some of these lymphocytes had a higher NC ratio and more condensed, angry-looking chromatin. So a flow cytometry was done, and this flow cytometry revealed, in the interest of time, I'll just say CD5. I think these are some T cells which are getting mixed up, but it revealed a kappa restricted uh, 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 B cell population, which is CD22 positive and CD20 nice and bright, and CD3 negative. Yeah, I think this must be coming from somewhere here. Now in this patient with Hodgkin lymphoma, we're getting a B cell light chain lambda kappa light chain restricted population. So what's going on? So when the biopsy came, it corroborated our marrow impressions, because we're seeing a lot of these infiltrates, which are lymphoid aggregates. And on closer examination, these are paratrabecular, and some of these may be intrasinusoidal as well, and very small monotonous cells. And then there are areas of hypocellularity, which turned out to be fibrotic. And in those areas, we're finding these larger cells as well, with prominent nucleoli in a background of small cells. And these cells, some of these were binucleate, some of these were mummified, some of these had multiple prominent nucleoli. So really, is this Hodgkin infiltrate and with a very reactive background? But then how do you explain the light chain restriction? So this is the CD20, and we're seeing the paratrabecular aggregates over here. And this is a non-paratrabecular, but we can see them. And sometimes, the same aggregate can wrap around trabeculum. So if you're seeing one here and one here, they may just be the same. And in addition, these are the larger cells. And let me see. The, so they are negative for CD20. This is CD3, is just forming a rim around those aggregates. These larger cells are negative for CD3. They are positive for CD30 with a very typical Golgi accentuation. And this is a closer look at the CD30 or in those binucleate cells. CD15 was positive in the neutrophils. These cells were largely negative, and CD45 was very difficult to interpret, but under oil immersion, we could make out that these cells are CD45 negative. So, and the ALK protein was negative in these cells. So in this elderly male being staged for Hodgkin's, we found that we have a clonal B cell population as well as immunohistochemistry showing us that the large cells are fitting the immunophenotype. So this is a composite lymphoma, which is in which the Hodgkin and SMZL are the commonest varieties. And I think I'm going to overshoot my time now, so I'll skip this slide. So SMZL and Hodgkin is a very rare combo, and which is what our case was as well. So in conclusion, I'm not going to read through this. I didn't put in conclusions, but I put in questions. And this is something that we do in our DM seminars. Dr. Malhotra encourages us to do that. We put in research questions, but these are mainly the learning objectives, which I was hoping to cover in the course of the last hour and probably 5 minutes. The significance of bone marrow evaluation, the frequencies, what is an adequate specimen, what is the information that the pathologist needs, reactive versus neoplastic, so important, and common patterns, discordant patterns, ancillary studies, and then diagnostic challenges. So with that, I'm at the end of my talk. This is my uh, email address. If somebody wants a pared down version of this, I'll have to remove some of the slides which I've borrowed from people, but you're most welcome to have it. I would also be happy to share with you in the course of preparing for this talk. I should thank the IGHBT. I came across nice resources dealing with this topic, which I think might be of use to residents and practitioners both. So with that, that's the end of my talk. Thank you very much. So just email me and I'll be happy to email you if you need those references.
Thank you, sir. So I think there is 1 or 2 questions in the chat box.
Okay. Should I stop sharing?
Okay. Yes, sir.
Okay. Bring it on. There is the chat box. So there's a good evening from Snevarsha. Hi, Snevarsha. Can Richter transformation be suspected in a bone marrow biopsy? If it is, hello, Dr. Jyoti. So nice to meet you here. Well, the answer is yes. And we've had lovely, intriguing cases of Richter syndrome, which were caught on the bone marrow. It's, of course, much more usual for them to be diagnosed on a lymph node biopsy, and PGI, those are seen by histopathologists led by Dr. Amanjeet Bal. But so we've had a case where So what can sometimes happen is that the patient will have a CLL clone. They will have a longish history, and in the bone marrow, you will get an abnormal cellular population as well. And we had a very interesting case, and our senior resident, Dr. Durga, wrote that up along with Dr. Praveen Sharma. He saw the flow cytometry for that case. The bone marrow had been reported by me. The Those cells were polyploid, those abnormal large immunoblasts. I think they were tetraploid, if I remember right, and they were caught actually on the FX cycle violet on the flow cytometry, in addition to their abnormal phenotype. So if you're seeing a population which is looking like abnormal large B cells, could be immunoblastic, and you're seeing a CLL in the background, or the patient is a known case, then we will have cases. We had one more recently, but there that remains unproven. And Dr. Tripathi and Dr. Khadija correctly guessed the questions that I was asking, and so did Dr. Sani. And so iPhone 234 wants to know the decal procedure for the bone marrow. There are, it's a plethora of approaches you could take. I could tell you what we do in I mean, in PGI, we have over the years, Dr. Manupdesh looks after that section along with Mrs. Manju Goyal. So they've experimented, but most of the times, in the interests of time, as well as, so, okay, let me put it this way. You can do it with a strong acid like dilute HNO3, or you can do it like with a weak acid like the EDTA. Uh, so the strong acid will be faster. It'll not harm the morphology too much. And in most cases, it'll be okay for IHC. If you don't put IHC on a routine, if you have a very good flow cytometry system like we have, then you can go in for the nitric acid. If, however, you do a lot of IHC, then you're going to prefer EDTA. It takes slightly longer. There is a Hammersmith protocol. You can look at that. There is zinc, I think, something acetate. You can check it up. It's been a long time since I read that. They are a little faster. Those protocols are very good for IHC. So that's something that you'll have to take a decision based on your practice and what's more important for you. So you're most welcome, Selvan. My pleasure. So Nandini is asking how to distinguish between hematogones and blasts in ALL. May I propose that we have amazing flow cytometrists? That's a decision that often is made on flow cytometry, especially in the very tricky circumstance of a regenerating marrow post-induction in BALL, right? So that really won't come as a lymphoid infiltrate. So I'll leave that to another because you need to look at the immunophenotypic findings, you look at its synchronicity, and you need to look at being stuck at one stage, and you need to look for aberrancy. So in a nutshell, but obviously it's more deep than that. What I will say is that distinguishing hematogones from lymphoblasts is not impossible morphologically. Sometimes I hear people say things like, there's no way we can distinguish it. No, most of the times, even before the advent of flow cytometry, we were making that distinction with a very high degree of accuracy. Flow cytometry, of course, puts a very neat laser-like cut across these two categories and helps us distinguish them. So I know I haven't answered your question, Nandini, but in the interest of time, I think you'll forgive me. If you're still here, that is. Okay, some IHC markers don't work well on bone marrow biopsies, like cyclin D1. Really? Yeah. So, maybe that problem. So the thing with cyclin D1 is that it works better on tissue sections. And obviously by there, I mean undecalcified sections, like they come in histopathology. So as opposed to flow cytometry. So I'm sure that's your experience as well, Dr. Tripathi. She's a specialist hematologist for those who don't know. But again, I don't have an experience like that. In my experience, cyclin D1 does work well on bone marrow biopsies as well in the odd. So cyclin D1 is sometimes, of course, other than mantle cell lymphoma, also required when we're looking at the odd myeloma with lymphoplasmacytic morphology, because there's an overexpression. So I think this is something that that has not been my experience. So Prerna, thank you very much for the compliment. And how often do you encounter marrow fibrosis in T lymphoma? Not very frequently. So fibrosis classically, of course, is hairy cell and Hodgkin, and I'm talking about the pre-therapy marrows. Um, and even in the PTCL NOS, the follicular T helper cells, it is not a frequent finding. If it's there, it can frequently confound the um, interpretation because your flow cytometry specimen is going to be compromised, is likely to be compromised. One workaround against that is if the marrow is coming extremely diluted, what we do here at PGI, following a study that my ex-student and now colleague, Dr. Karthik Bomanan, had done, was that they looked at bone marrow trephines, which were placed in saline and then agitated vortex to release the cells, and that saline wash or the trephine wash becomes an alternative sample for flow cytometry. Um, Thank you very much. Do you have any data? Dr. Dinesh is asking regarding unilateral versus bilateral biopsies for lymphoma infiltration. Uh, I wouldn't have it from here because we always do bilaterals. There have been excellent studies on that, Dinesh. So, uh, and there the involvement rates tend to will invariably go up with bilateral biopsies. So my suggestion to a center which is struggling with the fact that the biopsies are being done by clinicians, or the fact that the bilateral biopsies increase, procedure time, infection risk, blah blah, cost. What you could do is that in those staging marrows where involvement is going to make a big difference to the management, for example, DLBCLs, etc., you could go in for a bilateral, or but in case in this group would also fall the plasma cell neoplasms, because you need to know the plasma cell percentage in the bone marrow, and sometimes they may be unequal because they are patchy. On the other hand, neoplasms, where the neoplasm is already there in the peripheral blood, for CLLs, for mantles, and sometimes for the other indolent ones, you could go in for a unilateral. But bilaterals are better, and the literature's out there. Prerna, what should be the appropriate kappa lambda ratio for clonality on BMB? Again, now this is something that I don't do practically, simply because I'm sure, like you too, we rely on flow cytometry. So on the odd case, and those are really, really rare, where we need to go in for this. So, Dr. Tripathi was asking about unsatisfactory cyclin D1s. On the other hand, we've always had issues with kappa lambda on immunohistochemistry, because with a lot of non-specific staining, and so much so that I haven't ordered these for a long time now, and I wonder if the technology has improved. So I think the appropriate ratio, Dr. Prerna, would be similar to the ones that we take for flow cytometry. So 3 to 0.5. I mean, anything outside of that, kappa to lambda. Yeah, but again, so maybe one of the conclusion slides I should have put is that it has to be an integrated approach. So if you're getting this kind of a situation where it's just down to the bone marrow biopsy, I would suggest take a deep breath, take a step back, say, now you give me the entire clinical data, you repeat a bone marrow for flow cytometry, depending on which neoplasm it is, for example, if it's LPL or hairy cell, the nice molecular markers, you go in for those, and then let's sit down, because a patient is more important than a single specimen or a single report. So an integrated report with all the inputs would probably solve the issue. Hi, Nishit, long time. So any insight on a mediastinal mass with spill in pleural effusion cases with ALL? Yeah, that happens with TLC, although you don't mention T cell or B cell ALL. Maybe TLC is 20,000, negative ADA, no blasts on peripheral smear. Okay, so that's interesting. So in the bone marrow, I'm guessing, I don't know, is the flow cytometry on the bone marrow or is it on the pleural fluid? Let's, for the sake of this talk, because this is on bone marrows, assume this is in the bone marrow that you're getting blasts. So if you don't get blasts in circulation, but the blasts are more than 25% in the bone marrow, and these are T blasts, you'll have to call it a T lymphoblastic leukemia, because it's more than 25, okay? Even if the blood is not involved. On the other hand, if you've got a pleural fluid which is showing the same blasts, but the marrow is showing less than 25% of those, it'll become a marrow involvement by that T lymphoblastic lymphoma. Of course, needless to say, the confirmation of whether it's a mature or a precursor T neoplasm would be critical in this case, and flow cytometry would tell you that. Thank you very much, Priyavadna. Not very crisp. I'm already at 8:10, but for the crisp talk, can I comment on bone marrow necrosis and IHC? Yes, bone marrow necrosis can be very problematic. Just today, we ran a case where it was a relapsed BALL, but we couldn't confirm it on flow because in a relapse, we typically end up doing the entire Luke panel on flow again, just in case it's evolved to something else. So, but we couldn't do it because the marrow was completely necrotic. IHC in such cases, in my experience, has to be interpreted with a lot of caution because we don't want false positives coming. So if you have a marrow which is partly necrotic and partly viable, and that's often the case, you could report it very carefully comparing the two areas. But if it's completely necrotic, sometimes it's a good idea to repeat the aspirate from the contralateral side um, if IHC is um, critical, if an immunophenotyping is critical. But you've worked with Dr. Basu. I'm sure you have your own wonderful experiences with this. So do correct me or update me if I'm missing something. Hi, Astha. Uh, Do you also evaluate plasma cells in a suspected case of LPL? Well, yes, because often by the time it goes to flow, the distinction between an LPL versus a myeloma, which is having a lymphoplasmacytic morphology, is not clear. So we typically look at that. And Dr. Prakash, thank you very much. Atypical CHL with MUM1, CD30, GATA3 positivity. Okay, so far so good. And PAX5 negative, 15 negative through histomorphology. So, I'm a hematopathologist, Dr. Prakash, so I don't see the full spectrum of these kind of rare Hodgkins, which for which my colleague Dr. Amanjeet Bal or even Dr. Pulkit Rastogi, who's a former histopathologist, now back to hemat, would no. So I think because I wouldn't want to. So the answer to your question is no. And that's because most of the Hodgkins I see are the ones which are already diagnosed on a lymph node. So unless there is something very, very unusual, like the last case that I showed you, I just on just the HE, or if it's very, very complicated on the CD30, I just say this is now showing involvement, and I leave it at that. Okay. We're nearly at the end of the question. So, Prerna, again, should we consider applying IHC in cases of low-grade lymphomas in which there's a mild interstitial increase in lymphocytes but no aggregates? So the answer to that is the answer to that depends on whether you have flow cytometry on that specimen or not. If you have flow cytometry, which is showing, and the patient is a known case of a low-grade lymphoma, or has a big spleen, very likely to be an SMZL, let's say, and on your flow you're clearly getting an SMZL or a LPL, okay, and you have a biopsy in which you have an interstitial increase. The flow is clear-cut. There is no doubt there. I'll be honest, often we wouldn't go in for IHC simply to quantitate the tumor load, because that's the additional advantage that would get by doing IHC on the bone marrow. The bone marrow is already involved. That's clinched. On the other hand, there will be situations, for instance, say a patient has autoimmune hemolytic anemia of the cold autoantibody type. Okay, so you're doing a flow, you're getting a very low grade B cell population, which is monoclonal on flow, but it's very, very small. So there, we would do immunohistochemistry in this low-grade lymphoma because we want to be 100% certain that the AIHA is resulting from this. And of course, WHO has a category for this now. So it really depends on the situation. And at least in modern busy practices, if you have a clear-cut diagnosis of lymphoma coming from any of the ancillary techniques, and of course, that's why it's important to be aware of their pitfalls as well. So if you have it coming from there, IHC, and don't kill me for this, is not mandatory. Yeah. How common is discordant involvement in your experience? Is very common. And while on discordant, I maybe I'm just so the organizers I'm trusting will let me know that when the time is really, really up. Okay, but this is an important question. So discordant morphology does come from time to time, and and typically it is a large cell in the periphery and the and a small cell in the bone marrow. Sometimes DLBCLs, which are involving the bone marrow with a small cell morphology, can aberrantly express CD5 as well, and there it can be very tricky to not overcall it as a second lymphoma, or at the same time not miss a monoclonal B cell lymphocytosis. And of course, we all know the immunophenotypic differences between DLBCLs and a CLL kind of an MBL. MBL can be both CLL types and non-CLL types. So, and sometimes even CD5 negative types. So in such cases, one again needs the complete immunophenotypic panel on the flow cytometry, as well as possibly immunohistochemistry, and if possible, FISH to look for the translocations, which you would look for anyway in a CD10 positive neoplasm, if your DLBCL is that. So yes, we do get it, and I'm sure everyone does from time to time. Is it possible to have nodal involvement by lymphoma and the marrow involvement by lymphoma and the node not showing this histology? Yes, indeed. And in those cases, one needs to be really sure that there isn't a site that's being missed. But if you can't find any and the marrow is still, you're 100% certain is showing a lymphoma, then one needs to call it a primary bone marrow lymphoma. Thank you very much, Khungar sir and Dr. Ruma, madam. And Nishit just clarified that his case was about the bone marrow. So hopefully I answered your question. So Adnan, you can check the recording on the ISHBT website. There are other lovely, lovely recordings over there. Dr. Dinesh, Dr. Jasmita, Dr. Tathagat Chatterjee. There are so many. I couldn't even begin to list them on very, very practical, practice-oriented topics. So Dr. Gurleen is asking, so I would really encourage people to check out the ISHBT website. This is the case of a 64-year-old male with lytic sclerotic lesions, no other symptoms. Something's getting covered. Pan CK negative with LCA negative, but CD 68, 4. Wow. And this is a lymphoid infiltrate, I'm guessing, that you're describing. So now with LCA negative, and I'm assuming that you've not written it, but CD20 and CD3 are negative, right? I'm looking at Dr. Gurleen's question about a 64-year-old male with a lytic lesion who doesn't seem to have a hematopoietic cell, or at least not the positive ones, not the CD45 positive ones, but has CD68, 4, 56, and right 33. So, my thoughts are immediately thinking of either a blastic plasmacytoid dendritic cell neoplasm. So there are ways to confirm that. And usually the aspirate and the blood would show you cells there. If that's been conclusively excluded, I would think of a histiocytic neoplasm with this sort of a profile. I would be looking for Langerin and CD1A and S100. And great, so you thought of melanoma. That's always useful to rule out, probably a neuroendocrine tumor. These cases are toughies, and yeah, sometimes probably one needs to send it back to the clinician, look for a primary and get back to me. One, of course, would need to correlate it with what has the patient come with. Is there organomegaly? Is there cytopenia? Is there a past history of something? This was a tough one. Sorry to not be of more help. Um, so that's Dr. Selvan, our ex-student, now in Delhi, doing his DM. So if PET shows only a physiological level of uptake in the bone marrow, in a known case, with Selvan, they're all googlies, so I better read this carefully. In a known case of lymphoma diagnosed on a lymph node biopsy, should we still go for a bone marrow procedure? No, I'm sorrier than you that it's way beyond scheduled time. But you know how it is for classes in PGI, we never know when to stop. Yeah, so we're looking at a patient who's getting staged, right? And right now they've done PET, but they haven't done a bone marrow. And on the PET, there's a physiological level of uptake. So I'll refer you to the PET people for this. This is an issue that is still evolving. It's different for Hodgkin versus non-Hodgkin. And if you've got a physiological level of uptake, then in some situations, the bone marrow will get omitted. Yeah. So sorry for the brief reply, but as you say, it's way beyond the scheduled time. So back to Dr. Gurleen's question, LCH typically is relatively easy to confirm, right? I mean, a CD1A and a Langerin, you would have done that. And so is that negative? And LCH cells, LCH, 64-year-old could be LCH, lytic sclerotic lesions, slightly old. Typically, in older people, we tend to get the pulmonary kinds more. And I can see my friend, Dr. So, Dr. Gurleen, I'm still at sea. I think this is a discussion to be done over coffee and lots of leisure time rather than this kind of written communication. So, I can see Dr. Kushwaha from Lucknow. So, they have a 60-year-old female with lytic sclerotic lesions. They're very common, it seems, nowadays. So, inguinal lymphadenopathy, grade 3 myelofibrosis, JAK2 positive, and CD20 positive nodules. Wow. So, so if a JAK2 is positive, then we need to be really, really sure that that list of myeloid lesions which can show JAK2 positivity is excluded. Okay, ma'am. So I would need to know this patient's counts in the peripheral blood. I need to know the status of the spleen, whether there have been any thrombotic episodes or anything which would suggest a thrombosis, like a um, portal hypertension kind of a situation, because that's a very difficult result to ignore. There is myelofibrosis, and that we know can have multiple causes, including conditions which have a JAK2 positivity, which means the MPNs and the MDS MPNs, where this comes. So inguinal lymphadenopathy is unusual. You could put a needle in there. Sometimes you can get extramedullary blast crisis in the MPNs, or you can get infections in primary myelofibrosis. Those things can happen. Now you've done a biopsy and you're getting CD20 positive nodules. We need to immunophenotype those nodules. My guess is they will not show clonal B cells. They would be the usually T cell rich nodules that we see in PMF and PV. A lymph node biopsy is a very judicious step, and please do let me know what this case turns out, because and I'm assuming that the JAK2 is, of course, the V617F, and that's, so of course, there are lymphoid neoplasms which can be associated with clonal hematopoiesis of the myeloid types, right? So I think we all know of the follicular T helper cell lymphomas. They can have clonal hematopoiesis associated with them, and there one can have a JAK2 mutation, which is an acquired mutation representing their clonal hematopoiesis. So again, we need to note at the technique and the mutation load with which this was diagnosed, so that we know we're looking at a very, very low level mutation, or we're looking at a predominant clone. We need to, I think the lymph node biopsies would be very interesting. If they've got multiple lymph nodes, you could even try an FNAC on one. Cytologists, cytopathologists are very good at diagnosing extramedullary hematopoiesis or blasts. Most centers do flow cytometry on lymph nodes nowadays. So they may make a biopsy, not mandatory. Okay, Dr. Gurleen, you've put CD1A, but CD1A is negative. Yeah, thank you. Yeah, then it's tricky. Then LCH, more likely, if it is in histiocytosis, which was the second thing that I said we would think of, it would be a non-Langerhans cell variety, because they tend to be CD1A negative and Langerhans negative. And no thrombotic episodes. And you've, so back to Dr. Kushwaha now. This is fun, actually. It's like, so no thrombotic episodes. And on FNA, there is EMH, extramedullary hematopoiesis with many atypical cells. So, my guess is you're looking at an MPN, right? Because a lymphoma is less likely to show megakaryocytes and myelocytes and erythroid precursors. And yeah, so uh, I think in the bone marrow, is there any indication? What about the counts? You need to look at that. You need, so the JAK2 is not just the MPNs. It could be the RARST. It could be some cases of CMML. Um, and so on and so forth. Now they've removed the MDSU, and God knows why, but some cases could have had a clonal thing there. Again, very difficult cases, and I'm sure all of these which are being put up. And that truly makes hematology so interesting because it's a multi-disciplinary meeting, even within hematopathology is what I mean. Multi-technology. It's like a fusion of inputs from so many different sources. So I think I've scrolled down till the end of the presentation, and there are 44 people who are still left. And if I exclude maybe 10 organizers and speaker, um, that's still 34 people. Um, uh, Thank you for sticking it out for so long. And I hope you've managed to grab dinner alongside, or will do so shortly. It was lovely being here and the whole present. So please do write to me if you. I found a very nice book chapter on lymphoid infiltrates, which is very high yield. It's in a question answer kind of a format. Some of you may already have it. And I obviously don't want to put it on groups for various reasons, but I'd be happy to share it with anybody who's interested. So thank you and good night and bye-bye. Thanks. I'll
Thank you,
sit.
sir. Thank
Yeah.
you, sir, for such an interactive class. So, can we end here?
Yes, my pleasure, madam. Thank you very
Good
much.
night, sir. Good night, everybody.
Good night, everyone. Good night, doctor, and good night, beauty.